So it looks like we have a good number of people, so I think that we can start. So welcome everyone. Thank you so much for joining the CADASIL Consortium for tonight's webinar. Today we'll have our site principal investigator at UCSF, Dr. Michael Geschwind, who's also co-PI of the study. And tonight he'll be discussing some of the unanswered questions in CADASIL and its management. And if you have any questions, you can save them for the end of the webinar, where we'll have some allotted time to input questions into the Q&A box. And yeah, I'll let Dr. Geschwind take over.
Good evening to those of you who are joining, depending upon where you're calling in from. So I'm Michael Geschwind. I'm a behavioral and movement disorder neurologist at University of California, San Francisco. And I've been interested in CADASIL since about the early 2000s, when I was an investigator in the first treatment trial for CADASIL in the United States, trying to treat some of the cognitive symptoms of CADASIL with the medication donepezil, which is a medication that's been used and approved for Alzheimer's disease since 1996 in the United States. And since then, I've built up a cohort. We have about 80 patients we've seen at UCSF over the years. And the reason for this webinar is that in a lot of the patients I've seen in clinic and patients who are coming into our CADASIL Consortium study, which I'll talk about briefly at the end of this webinar, we get a lot of really great questions from patients and families about how to manage CADASIL. And so I wanted to discuss some of the many unanswered questions in CADASIL and its management. So the way that I'd like to do that today is, let me see if I can get my slides to advance. This is the outline. So a lot of what I'm going to say is my opinion, but I'll try to be pretty careful about saying when it's my opinion. And then I'm also going to cite papers, including there are two papers that I think are helpful papers on the management of cerebral small vessel ischemic disease, particularly those that are caused by genetic mutations. And one paper came out in 2023 from the American Heart Association, and another came out in 2020 from our European CADASIL and small vessel ischemic disease experts in Europe. And these are just guidelines, and I'll talk a little bit more about those papers. What I'm going to do is I'm going to list several questions, and it's not meant to be a complete list. It's just a list that I and my colleagues have encountered by several of our patients. And we try to keep a running list of these, and it's not meant to be comprehensive, but we tried to talk about some of the more common questions and about how to manage CADASIL. And I'm going to present them, and then I'm going to present the questions, and I'm going to try to answer them. For some of them, there will be more formal answers where there are some guidelines, and others are just going to be sort of, this is how I do it. And I think there are some other CADASIL consortium experts, so some of my neurology colleagues who might be on this call and might also give their opinion tonight too. Just because if you put 12 CADASIL experts in a room and you ask a question, you might get 12 different answers. But hopefully there will be some things which there can be a consensus about. So I'm first going to list the questions without providing any answers. So what about if you think you're having a stroke, or you're not sure if it's a stroke, a migraine, or a seizure, or other type of episode, when should I go to the emergency department? When should I go to urgent care? What should I be taking to prevent stroke of CADASIL? Should I be taking antithrombotic medicines such as antiplatelet medicines like clopidogrel or baby dose or low dose aspirin? Should I be taking oral anticoagulants to prevent coagulation? And then what happens if I'm in the middle of what is a stroke? Should I be getting a clot-busting agents Often they give these intravenously in the emergency room to break up a clot or that is occurring either during a stroke or a transient ischemic attack or a TIA, a transient ischemic attack. Some people call a stroke, a transient ischemic attack, a mini stroke. Kind of one definition that's maybe a little outdated, but if you're having neurologic symptoms due to brain ischemia that last less than 24 hours, then they call it a TIA. If you actually have symptoms lasting for more than 24 hours, it's a stroke. The bottom line is that the TIA and a stroke are a continuum of the same thing. It's a lack of flow of blood to certain parts of the brain that result in neurologic symptoms. Some of these symptoms could be face, arm, leg, weakness. It could be sensory symptoms, often numbness, tingling. It could be a language problem, so a problem with speech. So weakness, sensory symptoms, often a lot for sensory, it's a loss of symptoms, so often numbness or a loss of feeling. Sometimes there's pain with the stroke, which can make it difficult to differentiate from a migraine. But the important thing is that if you think you're having a TIA or a stroke, should you be getting a clot-busting agents to break it up? And we'll talk about why of those. And then what about migraine prevention? About a third of patients with CADASIL have migraines, and there's a question in the field about how to treat them. There's a class of medicines called triptans. The name of the drug often ends in the word triptans. Sumatriptan would be a classic example. The trade name for that is Imitrex. These are medicines that are given to abort or to stop a migraine when it has begun, and or when you feel that the migraine is about to come on, such as if you're having an aura that precedes your migraine. Are these safe to take? People who don't have CADASIL migraines, this is one of the first line abortive treatments, not a preventative or prophylactic treatment. Are CGRP inhibitors safe in CADASIL? This is a whole new class of medicines that block the calcitonin gene-related peptide receptor. They're often given intravenously, though some are coming out that aren't intravenous. Some can be nasal now. But are these safe in CADASIL? Should you be taking acetazolamide, or trade name is Diamox, as a preventative or prophylactic treatment to prevent migraines of CADASIL? Should I be taking magnesium supplements or other things to abort migraines? So I'll discuss some of these questions, and then when should I test for Notch3? Should I get at what age is it appropriate to test children? When and if should I get a skin biopsy? Is a genetic test or a skin test considered best? And what about lifestyle for CADASIL? What about diet and exercise, cardiovascular risk factors, stress, weightlifting? And I'll discuss kind of mostly some of my thoughts and some of my colleagues' thoughts when we've discussed this. What about pregnancy? Is it safe in CADASIL? What do we know about it? So I alluded to two very nice papers that have, over the past 4 years, have pulled together some experts in small vessel ischemic disease, particularly genetic disease. And one of the main causes of genetic forms of small vessel ischemic disease is CADASIL, but there are almost a dozen other genes that are involved in other forms of diseases that are somewhat related to CADASIL, and that they can cause small vessel ischemic disease and strokes. So the bottom paper came out in 2020 in the European Journal of Neurology. And this was a very systematized paper where they actually asked many of the European investigators, experts in CADASIL, they sent them a list of questions and how they would deal with this. And they had a very systematic way of answering this. And it was a pretty scientific study how they did it, but it was still the opinion of some experts. And they also tried to review the literature when the literature was available. For the top paper, this was a paper from the US, from the US American Heart Association. And it's here are some of the people who were involved. And they had a committee in the American Heart Association. It was chaired by Dr. James Meshia from Mayo Clinic, Jacksonville, and a CADASIL expert, and then several other CADASIL experts, clinicians, basic scientists. Dr. Wang is a clinician and a basic scientist. Some of these people, Dr. Gutierrez from Columbia, Jennifer Majerzik from Utah, they're part of our CADASIL consortium study. Fanny Lahi is and Dr. Mashia are running a study funded by the Chan Zuckerberg Initiative. Dr. Lahi is now out of Mount Sinai, though she and I used to work together very closely at UCSF. So a lot of really great CADASIL experts here, but still a relatively small list. And they went through the literature, and they also kind of came up with a consensus about several aspects of many of the questions that we're dealing with today. And I will try to give, I'll note when each paper has a reference for a certain topic as we go along. So, so one of the questions is, when should I go to the emergency room? And there's no, this is a question which I'm just going to sort of give my own opinion, but, and my opinion really is very patient specific. So some of my colleagues, when I asked this question, they said, anytime you have a symptom that you think is neurologic, that is not part of your classic migraine, for example, but is something different. If you have sudden onset of weakness, if you have a change in vision, if you have inability to speak, and it's not associated with your typical migraine headache, some clinicians would say you should definitely go to the emergency room. And there are pluses and minuses for that. I have patients who recurrently have symptoms. We still are never quite sure, is it ischemia? Is it transient ischemic attack? They often go away after a few minutes, or is it a migraine? But in general, I think most clinicians would say it's better to be conservative and to be safe. And if you go to the emergency room and they do an MRI, for example, or they do a CAT scan, and they see that there is a recent ongoing stroke, usually less than 3 hours, in some cases a 3 to 6 hour window from onset, you might be eligible to get some clot-busting agents. They also might be able to, even if you're not going to get the clot-busting agents for a variety of reasons, either it's just you've already decided it's too risky with CADASIL, there are too many unknowns. You might have decided with your doctor that you're not going to get it, especially if you're not sure if it's a stroke, or could it be a migraine, a complicated migraine where you're having neurologic symptoms. Or maybe you're already on basic treatment. Maybe you're already taking aspirin or Plavix. So there are lots of reasons why you should or shouldn't go. In general, it's probably better to go to the emergency department or the ED or the ER. I think in most cases, unless it's very clear that what you're having is one of your typical migraines. It's very uncommon, but some people can have seizures with CADASIL. And if it's a seizure that you've had before, that might be another reason. But seizures can also be treated in the emergency room. If it's a seizure that lasts more than a few minutes, if it doesn't go away or if it reoccurs, you might want to be getting urgent treatment with an anti-epileptic medicine in the emergency room. So that would be another reason to go to the emergency room. But I recommend that all patients have this discussion with their doctor, and some of it will be based on the discussion we'll talk about later in the next few slides, such as, should I be taking antithrombotic medications? Again, these are medicines that either stop blood from clotting, so anticoagulants, or they're antiplatelets that prevent platelets from from aggregating and forming a clot. So there are two different mechanisms for antithrombosis. You could either stop the coagulation cascade, or you could stop platelets from aggregating. Platelets from aggregating would include medicines such as aspirin or clopidogrel, most commonly in the United States. And then anticoagulants, we'll talk about in a little bit, but they used to be medicines like Coumadin. Now it's more common to give other medicines that are oral anticoagulants that are easier to take and don't require the monitoring that you needed with Coumadin. And then what happens if I am having a stroke and they document it in the emergency room, either by CT or MRI, I'm having symptoms, should you get clot-busting agents? And the dogma in the literature, well, the dogma in the field, I should say, by many clinicians who are experts in CADASIL is that there's a theoretical risk of increasing bleeding. A minority of patients with CADASIL, maybe estimate of a third or roughly a third of patients, might have small bleeds in the brain, what we call microbleeds. And we can see these on a certain MRI sequences. It's one of the common sequences we do in all of our patients who are known to be at risk for CADASIL or are known to have CADASIL. And we see in some patients that they have these very tiny dark spots, which indicate that there are small bleeds that have occurred in the brain. Other diseases, other conditions can also cause those bleeds. And if you give a clot-busting agent, that patient who already has some bleeds, perhaps they're more likely to actually develop a larger bleed. There's data for people who don't have CADASIL that if you have a certain number of bleeds, or if the bleeds are in the brainstem, the back of your brain, kind of the part that leads up to the brain, the top of the spinal cord, that area, if you have bleeds, microbleeds there, you're at higher risk for having a larger brain bleed if you get a clot-busting agent. So let's talk about, should I be taking antiplatelet medicines, aspirin, clopidogrel, Plavix? So some clinicians follow the general stroke guidelines in the United States for healthy older adults, which are to not start persons on antiplatelet agents such as low-dose aspirin unless they've had a stroke or TIA. So that would be the only reason. The European guidelines say that there's no evidence to support antiplatelet agents in CADASIL in patients who have not had a prior stroke. If they have had a prior stroke, just like the guidelines for older adults who don't have CADASIL, then there's usually an indication for giving at least one antiplatelet agent. Usually we'd start with low-dose aspirin, which is 81 milligrams, also called baby aspirin. They're all the same thing. Low dose, baby, 81. In the United States, we consider these kind of synonymous. But many clinicians, including myself, I offer pre-symptomatic patients with people who are mutation carriers. I offer them low-dose aspirin, and I discuss the theoretical risks. There could be a risk for brain bleeds. But my decision about whether to offer that would definitely be influenced by whether or not the patient has brain bleeds, has microbleeds. Certainly if they have a lot of brain bleeds, so over 10, or if they have bleeds in the brainstem, I generally would avoid aspirin. But if they don't have that, my decision for most of I usually recommend that my patients take aspirin, particularly when we don't have anything else to offer them. Can I say that there's any data supporting that this helps patients with CADASIL? No, there's really no good data suggesting that it helps. There have been some small studies showing that there's really no decreased incidence of strokes or transient ischemic attacks. But my feeling is I don't have anything else to offer them. Maybe in some people this could help, but it's hard for me to argue with my colleagues who don't offer this unless a patient with CADASIL with a mutation had had a TI or a stroke. Interestingly, a survey of They did a very nice study in Japan, and that's the Shindo et al. Paper down here. And when I'm referencing papers, I will list the last name of the first author, the year, and the abbreviation of the journal on the bottom here. So if people want to go look them up, you can kind of Google these on the web. And a Japanese study by Shindo et al., they surveyed all the CADASIL experts in Japan, and they had data on 88, and they also have a registry of patients with NOTCH3 mutations in Japan. And they found that of 88 patients, about 3/4 were on antiplatelet agents. So antiplatelet, and many of these patients were pre-symptomatic, many, if not all, were pre-symptomatic. So it seems to be relatively common to give antiplatelet agents in Japan. Another study by Mupa et al. And colleagues in the journal Neurologic Science, published last year, they did a study in which they found antiplatelet use did not seem to affect the incidence of either strokes or transient ischemic attacks or bleeds in patients with suspected CADASIL. It wasn't the most beautiful study. There were some problems with it. They didn't have confirmation of genetic CADASIL in many patients, or I'm sorry, in some patients, but they didn't find that it affected the incidence of stroke or brain bleeds. But as I said, many clinicians feel that the risk is low, so that low-dose aspirin has low risk, so why not give it to everyone? And again, the decision is something that you should talk about with your clinician, and it certainly might want to be influenced by whether or not you have microbleeds on brain MRI. And certainly if you have a lot, regardless of whether or not you have CADASIL, aspirin probably would be a contraindication. A contraindication means that it's usually not recommended, not indicated, because it could be more risk than benefit. What about oral anticoagulant medicines? So oral anticoagulants, these are medicine. This is from the American Heart Association. These are sometimes called DOACs, direct-acting oral anticoagulants. They're sometimes called blood thinners. They're given to patients who have a tendency to have clots, a tendency to have deep vein thromboses, pulmonary embolisms, patients who have atrial fibrillation or what we call AFib. A common medicine that used to be given, a conventional anticoagulant was Coumadin, and another was heparin. This was given IV, Coumadin was given oral. And these DOACs, these direct-acting anticoagulants, are a newer class of medicines that are much easier to take and seem to be equally, if not more effective than some of the other medicines, but certainly much easier in terms of quality of life. And some of the names of these, they usually end in the word letters AN. So here's apixaban is one, Eliquis, and then here Xarelto is another, also ending in the ban. So these are just some of the 5 common ones in the United States. So are these safe in CADASIL? There's no clear answer. The European 2020 guidelines, they didn't recommend them for stroke prevention in general for stroke prevention due to the increased risk of brain bleed. But they felt that in patients with CADASIL, they were not contraindicated if there was another strong reason that a patient needed the medicine. So if they had a high risk score, and which I won't go into, but your clinician will know what a high cardiac or risk score, sometimes these are called CHAMP scores or CHAMP2, if there were risk scores, and another indication for having an oral anticoagulant, such as if the patient had atrial fibrillation, they had a lot of clots, such as pulmonary emboli or deep vein thromboses or DVTs. The American Heart Association guidelines that came out, they sort of went a little bit further, and they said, well, we kind of want to avoid giving these agents because of the increased risk of bleed. And if you do have atrial fibrillation, there are other ways of decreasing the risk. What happens with atrial fibrillation, it's often in the left atrium, the upper part of the heart, and the part of the heart that sends blood to the brain and to the body. And there's a part of that, an appendage, where sometimes there can be fibrillation. Instead of a good contraction, the contraction isn't good, and you get kind of almost looks like a bag of worms when you're looking from the outside. It's not pushing the blood properly, and the blood can stay in that area, and because it doesn't move well, it can form clots because it's not moving well. And one thing they can do and if that heart squeezes, it can send that clotted blood to the body or the brain, causing a pulmonary embolism, or I'm sorry, a deep vein thrombosis, or a stroke to the brain. So they say if there's an option to close the left atrial appendage, so there's an intravenous procedure that can be done to close that, you might want to do that instead of oral anticoagulants. But if you are going to take these oral anticoagulants, certainly that decision should be influenced by whether or not you already have microbleeds or even larger bleeds on the brain, because that would certainly increase your risk. And that's a discussion to have with your CADASIL physician or neurologist. So when a patient actually is having a transient ischemic attack or having a stroke, and they're having symptoms, maybe focal arm, leg weakness, it would usually be unilateral, meaning on one side of the body, either the right side or the left side, or and that could be numbness, it could be weakness, it could be just face, it could be face and arm, it could be face, arm, and leg. It could be sensory changes, often numbness. It could also, again, just be face, could be arm, could be leg, or any combination of those. If somebody is having a problem with the vision, particularly if it's not the entire vision, but a visual field. And what I mean by that is if it could be that you're having a problem with your right visual field. So if you close your right eye, you see there's a loss of vision on one side, maybe the right side. If you close the other eye and you look on that same side, you also see it. That suggests that there's ischemia or loss of blood supply to something in the brain. You can also have a stroke in the eye itself, not to where the vision is interpreted in the brain, but in the eye itself. And often in those cases, some people describe kind of a window shade, a blackened shade coming down across their vision. And that's a stroke of the eye, which is just as dangerous as a stroke of the brain. And those would be indications in a patient who didn't have CADASIL of getting a clot-busting treatment. But because in CADASIL, the blood vessels, particularly in the brain, are more friable, meaning they're not as, they don't expand as well. They have a tendency to break and to bleed because of the mutation and the effects it has in the membrane of the cells that line the blood vessel. There's a theoretical risk that these clot-busting agents could cause that blood vessel to bleed more easily. And if a person's having a stroke and then a bleed can be much worse for the brain. It can extend the area of the stroke. Blood in the brain, when blood gets out of the blood vessel and around the cells of the brain and around the blood vessels, it can worsen a stroke by causing the blood vessels to constrict. The blood vessels don't like having blood on the outside of them. And so a bleed in the brain can be very bad in and of itself, and it can worsen symptoms of a stroke and cause a larger stroke. And so we don't want bleeds. On the other hand, we also don't want strokes. We don't want that blood vessel to be blocked. And drugs like tissue plasminogen activator, these are drugs that we give through usually through a vein in the leg, a large vein, and we give it and we feed it up to the brain, and it can bust up a clot. And it's given often for large or for small vessel clots. It seems to be effective for both. And so if we could help a patient who's having a clot, maybe we should. And what's the risk of a patient with CADASIL bleeding versus curing that, preventing that stroke from worsening and maybe causing the symptoms to go away? So European guidelines state that patients should not get these clot-busting agents unless there's a large artery occlusion, meaning you have, so they've done imaging of your brain, and the area where the stroke is supplied by a large brain vessel. And usually in CADASIL, the vessels that are affected are tiny vessels. They're small capillaries, and they usually cause small strokes. But rarely you can have large strokes, like from a patient who has atrial fibrillation. Those clots can be very large and can block a large brain vessel. And that might be a reason for giving thrombolysis, even in a patient who has CADASIL, because the damage from a large vessel stroke can be very profound because so much of the brain can be affected. So that's the European guidelines, and but but there aren't studies really that have good studies that have systematically answered whether it's safe or not. Some of my colleagues who are stroke experts, if they had a patient come in with CADASIL and was clearly having a TI or stroke, and otherwise met criteria for giving the agents, so criteria are they're within a certain time period of the onset of the stroke, the severity of the stroke should not be, has to be a certain minimum severity based on a scale called the National Institutes of Health Stroke Scale, or the NIHSS, and the area of the stroke. Sometimes when we look at a stroke on a head CT or an MRI, we can get a general idea of whether the stroke is old, meaning many hours old, or whether it's probably very recent, like less than a few hours. And if it looks like it's an old stroke, meaning it's been there for many hours, over 12 hours, and we can see that on the MRI, then that by itself will increase the risk of a brain bleed, irrespective of CADASIL. And so those are patients on whom, irrespective of CADASIL, we might not give. If they don't meet the criteria for TPA, we wouldn't give it. But if a patient with CADASIL does otherwise meet criteria for TPA, some clinicians would give, stroke experts would give TPA. So there's no right or wrong for this. And I think it's important that you have this conversation with your doctor about what would you do. And you should let your family know about what your decision is, because maybe you may not be able to give your opinion during the stroke. You might be too incapacitated. You might not be able to speak. So it's good to think about these things in advance, discuss the plus and minuses with your family about what you would want. For example, some patients might decide that if they're young, they're otherwise healthy, they might want to have the risk of worsening of the stroke or causing a bleed if they can actually bust up the clot. A patient who maybe has a lot of, already is very advanced, has microbleeds, maybe they would make a different decision. But it's something that you should talk about with your clinician and with your loved ones. What about taking the oral anticoagulant medicines? So this would be the dogs. What is some of the data on that? Well, first of all, brain bleeds are pretty uncommon. Large brain bleeds are pretty uncommon in CADASIL, but a minority of patients will have these microbleeds. A study in Taiwan, and it should be noted that there is data in the literature suggesting how CADASIL presents based on one's ethnic background does seem to differ. So studies of CADASIL in Asia seem to differ from studies of CADASIL in Europe and the United States, and there might be different risks. So we have to be a little bit cautious about applying data from patients from Asia or Southeast Asia to patients of different ethnic backgrounds, because there are different stroke risks in people with different ethnic backgrounds due to other probably genetic reasons not related to Notch3. But a study in Taiwan, they looked at 255 patients with CADASIL, and they found that 15 of these, so 6%, had brain bleeds. But only 1 out of 15 could they clearly associate that brain bleed due to the use of oral anticoagulant use. So this study might suggest that in general, oral anticoagulant use, like with drugs like the Pixabans and whatnot, may not be that high risk, in at least in this Asian population with CADASIL. And again, this decision might be based on the presence of and the number of microbleeds. So studies in general have suggested that if somebody has microbleeds in the brainstem or greater than 10 microbleeds overall in the brain, that would be a person who's increased risk for brain bleeds from anticoagulants or thrombotics, and those people have a higher risk, and so you might not want to give the medicine, but that should be a discussion that they should have. European guidelines, so this is the Mancuso paper, European Journal of Neurology, I've already mentioned, feel that if patients with CADASIL have high risk factors for stroke and atrial fibrillation, or they have another indication for an anticoagulant, such as they have atrial fibrillation, a history of pulmonary embolism or DVTs, that oral anticoagulants are not contraindicated. So if there's another clear reason to give a patient with CADASIL, put them on an oral anticoagulant, then you should do so. So if a patient has AFib or a history of DVTs or pulmonary embolisms, then maybe it's best to put them on an oral anticoagulant. But again, no studies on that. Okay, I'm going to switch gears now and talk a little bit about migraine. So here are some of the questions. How should I treat my migraines if I'm at risk for CADASIL? Are the triptans, which are abortive medicines, usually given either orally or sometimes intranasally, sometimes you can inject them, are they safe in CADASIL? And the reason is because the reason we ask this is that in migraine, so these medicines, one of the mechanisms of migraine is thought to be this dilatation of certain blood vessels. It's called spreading depression, and you can get, it's kind of maybe counterintuitive, but some of the vessels can enlarge, and that seems to trigger pain receptors. And the triptans can constrict those blood vessels. So triptans, for example, might be contraindicated in a patient who has a high risk of heart attacks, because that it might worsen their blood vessels in their heart. And so maybe similarly, because it can narrow them, similarly, the brain vessels in CADASIL are narrowed, but and the triptans, the thinking is that vasoconstricting, meaning narrowing them further, might worsen the symptoms of CADASIL. So we'll talk a little bit about that. And what about taking acetazolamide? This is a class of medicines called carbonic anhydrase inhibitors. They are a class of medicines that are diuretics, meaning they make you urinate more frequently. They're often given to, they're given for blood pressure lowering. They're given to patients to people who have altitude sickness or who are going to altitude to prevent altitude sickness. And that's a different mechanism. It has to do with how it shifts the pH or the acidity of the blood, and that can affect altitude sickness. So anecdotally, meaning just through experience, many patients with CADASIL have seemed to have decreased migraine frequency and severity when they're on this medicine. So we'll talk about, should we prescribe that? There's a new class of medicines to treat migraine that have just come out over the past 5-10 years. And these are these are medicines that prevent migraines in people who have migraines. And they're called CGRP inhibitors. This stands for calcitonin gene related peptide. And it's actually the receptor. They're blocking the receptor. They inhibit the receptor. And they're very effective in patients with migraines. Are they safe and effective in CADASIL? And then another question is magnesium supplements. And actually, I don't know if I'll have time to go through that. So migraine treatments. So as I mentioned, some clinicians avoid triptans because they can worsen vasoconstriction and worsen vessel narrowing in CADASIL. So many clinicians instead use acetazolamide. A lot of clinicians use this. I use this routinely in my patients, and there have been lots of case reports, case studies showing that acetazolamide seems to be effective in many, but not all patients with CADASIL. And I usually start low dose with this. It does have some side effects. Some patients will get a numbness around. It's almost like they're wearing a headband of numbness. Fingertips can get, and toes can sometimes get numb and tingly. Usually those go away after you've been on the medicine for a while. Carbonated beverages such as, citric beverages, so grapefruit juice, orange juice, lemon juice. These can taste they can taste bad. They can taste very carbonated when you take these medicines, but eventually those symptoms usually go away. So the European guidelines, they found that there's no evidence contraindicating triptans in CADASIL, and they also found no evidence supporting acetazolamide, but they noted that the studies and trials are needed. And the AHA guidelines, again, noted that there's no real data on this, but there are certainly many case reports with triptans being given to CADASIL patients without clear worsening. My clinical practice is I tend to be a little bit risk adverse. I tend to avoid them if possible, and I'll start with drugs like acetazolamide, and only then, if they don't work, would I go to other medicines. I personally tend to try to avoid the triptans, and not because I have data, but because of the theoretical risk. But many of my colleagues in the CADASIL Consortium and in other studies do routinely give triptans. And I think it's a personal decision about this. Right now, we can't say there's a right or wrong in that. I realize I'm going a little bit slow, so I'm going to have to speed up, especially if I want time for Q&A. So I have about 4 slides left. So for migraine treatment with the CGRP receptor inhibitors, this is a monoclonal antibody, usually given intravenously. You take it every couple of months, or you can sometimes now take it, I think they're giving it now intramuscular or even nasally. But their data is that they're safe and effective in reducing the frequency and severity of migraine attacks. There are no guidelines in CADASIL. There's some data, some European researchers said that theoretically, because these CGRP inhibitors block vasodilatation of blood vessels, which might prevent it from allowing there to be more constriction, it could potentially worsen the ischemia of CADASIL. So sort of a similar mechanism to the triptans. And so they might recommend against them. But there's a building, gradually increasing body of evidence of many patients taking these CGRP receptor blockers or inhibitors successfully without clear worsening of CADASIL, without having an acute ischemic attack or a stroke. So the data is out. We really do need studies on these, and it's a discussion to have with your clinician. just some general things about when to test for Notch 3. So, what I usually tell people is, unless there's a clear reason for you to get your Notch 3 result, maybe delay the result until you really want to know. And certainly you should have genetic counseling. And the genetic counselor will, there are some very nice webinars on the Cure CADASIL site from Beth Croson, who gave 2 beautiful webinars on genetic counseling. And then Sumi Jayadev, a few weeks ago in May, I believe, end of May, gave a webinar on just genetics of CADASIL and the testing and the issues with that. So I refer you to those webinars. But for more of a background on this decision, but certainly you should have genetic counseling, and you should have thought about how would your life change if you find out that you do carry the mutation. How will your life change if you don't carry the mutation? Who would you tell? Would you tell your siblings who have not or have been tested? Would you tell your parents? Would you tell your children? When should you tell your children? All these are important questions to talk with your genetic counselor about. But what I usually tell my patients is that if you have a compelling reason for getting testing, such as you're getting married and you want to be clear with your spouse about your risk, maybe you are thinking about having children and you want to make the decision whether or not to go through pre-implantation genetic diagnosis, or PGD. These are reasons for maybe why you would want to know the result of a Notch 3 test. Alternatively, for instance, if you participate in a research study such as the CADASIL Consortium study, we can do the testing through the study, and it's kept separate from the actual investigator from the site. And you get counseling, and you can decide you don't want to get your result. But at a later date, you can decide, yes, I do now want to know it, and then you could redo the counseling and get the result. And then, should children be tested? And in general, we never, in neurology and genetics and medicine, we never test children for adult onset diseases unless there's a clinical reason to do it. So are you suspicious there's a family history of CADASIL and you're worried that the child might be symptomatic? Usually people do not become symptomatic with CADASIL, except for migraines, which are pretty common, about 10% of the population. But children with who are mutation carriers, Notch 3 carriers, they usually don't become symptomatic until their 30s, 40s, even 50s. The migraines usually might begin 30s. Other symptoms won't, like strokes, TIAs, usually not until one's 40s or 50s on average. So it's usually not a childhood onset disorder. So in general, we think it's unethical to test children unless there's a compelling reason. One of the reasons is you're denying that child the right to make their own decision, to wait until they're an adult and can make that decision on their own. And that's just a general thing, but it should be discussed with your genetic counselor. And then what about doing a skin biopsy? Is genetic testing or skin biopsy testing better? And usually nowadays, we think a genetic test is the best method. It's certainly easier to do. You can just send a blood test, and sometimes you can even just do a swab with like a Q-tip in the cheek and send that in to test for DNA. If the variant, if you find that somebody has a Notch 3 variant and it's not clear if it's symptomatic or not, then maybe doing a skin test to see if the skin shows the classic findings of CADASIL, which is called granular osmophilic material, or if they can stain for Notch 3 variant misfolding with immunohistochemistry. If they find accumulation of this Notch 3, abnormal accumulation by immunohistochemistry staining on the skin biopsy, those would be a rationale for doing a skin biopsy test if the genetic testing result is uncertain. What's best lifestyle? And my simple answer for this is always what's good for the heart is probably good for the brain. And that's what I recommend to all my patients who are increased risk for stroke or heart disease, irrespective of whether or not they've CADASIL. So I recommend a healthy, well-balanced diet, everything in moderation. Some people, the Mediterranean diet, reducing your cardiovascular risk factors, no smoking, if you're a smoker, stop smoking, good control of blood pressure. So just making somebody who normal blood pressure. We might not want the blood pressure too low in CADASIL because the vessels are smaller and maybe you need a minimum normal blood pressure to get blood going through. Just like we don't if a patient's having surgery and they have CADASIL, we want the anesthesiologist to make sure that the blood pressure doesn't get too low, because theoretically that might reduce blood flow to certain areas of the brain. So we want kind of normal blood pressure. We don't want the blood pressure too high because that increases the risk for brain bleeds for anyone, and possibly even more so for somebody with CADASIL. So for similar reasons, we want to reduce stress. We want to encourage a less stressed lifestyle. We don't obviously, you can't remove all stress. Work is stress. A lot of my patients do very complex, stressful jobs, but I recommend usually they do things to reduce stress. Mindfulness-based stress reduction, or MBSR, can be very helpful to reduce stress. If a patient has a lot of anxiety or psychiatric symptoms, we treat those psychiatric symptoms aggressively, just like we would with anybody with psychiatric symptoms, regardless of whether it might be due to CADASIL or not. One of my colleagues mentioned that she actually, one patient asked her, what about weightlifting? And, could that be, you're giving a Valsalva maneuver where you're holding your breath and you're pushing out? That might be something she thinks that she recommends her patients avoid a Valsalva. But, if you're just breathing normally while doing weight exercises, weight training is probably overall good for one's health, good for bone strength, maintaining strength. But you probably don't want to do a lot of weightlifting in which you're holding your breath and you're pushing and you're stressing your diaphragm, because that could really increase the blood pressure. Is pregnancy safe in CADASIL? So an Italian study of 93 pregnancies among 50 females who were Notch3 mutation carriers did not find a higher rate of complications, but they also noted that in that cohort, half of the patients were on antithrombotic medication, usually antiplatelet medicines like low-dose aspirin. So they're not sure if maybe the aspirin was helping. It's unknown. A Finnish study, they looked at 25 female carriers of the Notch3 mutation who had 43 completed pregnancies, and they noticed a much higher incidence of transient neurologic events occurring in the postpartum period, usually about 6 weeks after, I think it's 6 weeks after pregnancy. And they said that maybe that was the first manifestation of CADASIL. Another of my colleagues, and I'm not going to quote him because I don't want to misquote him, but I think they noted that in their cohort, that patients who during pregnancy, they felt that their migraines improved. And in some, even outside of CADASIL, some patients who have migraines, they can improve. And some patients, they can worsen while they're pregnant. And then it can change in the peripartum and the postpartum period. In the European guidelines, pregnancy and labor are generally uncomplicated in CADASIL, so there's no need for antithrombotics like half of the patients had in the Italian study. They claim that there's no need for that. We already talked about the anesthesia and keeping blood pressure. You want to try to keep it stable and not get too low or too high. And then there's other data that migraines and other transient neurologic events can be increased during pregnancy in some patients and also post-pregnancy, irrespective of CADASIL. So this is something that needs to be further studied, but pregnancy doesn't seem to really increase CADASIL risks, was kind of their general thoughts in the European guidelines. I didn't mention anything about magnesium treatment. To my knowledge, there's no, I would put it in the same category as the triptans and other medicines. We don't have good evidence that it's a risk as a prophylactic. I want to thank my colleagues, Doctors Biller, Majerzik, Jaidev, all part of the CADASIL Consortium study, for their feedback and input. The Cure CADASIL organization for patients and families, for all of their assistance in general with Cure CADASIL and their other webinars. I want to thank our patients and families and people in the CADASIL Consortium study. And with that, I'll take any questions.
And the questions are in the Q&A box, Dr. Geschwind. I
Oh, okay.
give these to you, or you can answer them yourself if you prefer.
Let me find the Q&A box. There we go. I got 5 questions. I heard that CADASIL strokes aren't quite ischemic strokes, nor hemorrhagic. Well, so what happens in CADASIL is that the blood vessels get smaller and smaller, and they get so small that it's even hard for single blood vessels, for single blood cells to pass through. So blood vessels can get blocked up, like it's like a clog in a pipe. And when those blood vessels start collecting, that can form a clot. You get aggregates of blood cells and you can form a clot. So in a sense, you are forming a clot in CADASIL. It can occur. So, but not always. So in some cases, the clot-busting agents might not help. But if there is a clot that occurs, because you are at higher risk just because the blood vessels are much smaller. And how about taking low-dose aspirin for CADASIL and stroke? I think that was an earlier question, but so that person logged on late. So the data is out on that. Some studies feel that it's safe. I think the guidelines in general state not to take aspirin in CADASIL unless you've had already had a TIA or stroke. Just like anybody who's had a TIA or stroke, they should be on usually an antiplatelet agent like low-dose aspirin. And I said I'm a little bit more liberal, and I tend to put my patients who are kind of older adults on low-dose aspirin as a preventative, even though there is no data. And the guidelines don't support giving low-dose aspirin unless somebody has had a stroke or TIA. A couple of questions here. Looks like a patient's sister has symptoms of CADASIL, including extreme vertigo throughout the whole day. They're involved in research. So I think this is a little too specific question. Migraines so vertigo or a sense of spinning can happen in CADASIL. When it happens all day, it's a little bit unusual, and we think about other causes, so migrainous causes, but this is something that certainly should be discussed with her doctors, and that vertigo should be worked up to see if there's a central cause of the vertigo, meaning could there be a stroke, or a peripheral cause, so it's a problem in the inner ear that has nothing to do with CADASIL. So that really should be worked up. To have vertigo all day would be uncommon, I would say, in my experience in CADASIL. What are the most typical symptoms of CADASIL? Well, usually a lot of patients will have mild cognitive impairment. It often doesn't occur until their 40s or 50s. It's often problems multitasking, problems organizing, planning, so what we call frontal executive. There are other webinars we've given. Dr. Jose Biller gave a nice webinar on a lot of the typical symptoms. It wasn't a topic for today, but there are other webinars that would be available on our website or on the Cure CADASIL website but strokes, transient ischemic attacks, migraines in about a third of patients, psychiatric and cognitive problems as well. Does every variant have granuloosmophilic material present? And I think my answer to that is I think that's still an unknown. Certainly all the cases that cause classic CADASIL, they're known to have GOM. I don't think there's great data on some of these variants that don't affect cysteine, but I could be wrong. There might be case reports in which, so most mutations that cause CADASIL either add a cysteine or subtract a cysteine, the amino acid. And the reason that's important is cysteines have sulfur on it, which sulfurs bind to each other, and it really affects the shape of the Notch3 protein. And so the more classic forms of CADASIL, the more severe forms, the more classic severe forms tend to have a notch, add or subtract a Notch3, and almost all of those, to my knowledge, have GOMs present. But some of the variants might not affect cysteine, and we think those cause a later onset, milder form. And we don't know. Some patients certainly have GOMs, but not everyone. And are GOMs similar to clots? It's a great question. No, the GOM is actually in the membrane itself. It's not in the blood vessel. The granuloosmophilic material is within the vessel wall, but not in the lumen or the opening of the it's where the blood cells are. So they're distinct. And differences in CADASIL presents in male and female, not to our knowledge, not really known to be differences, with the exception of what we talked about in pregnancy, as men generally don't get pregnant. What are your thoughts about Botox being used for migraines? Yes, I think I should have mentioned that. I think that's an alternative. Botox has been shown in some patients to be very helpful for certain types of migraines, and especially if acetazolamide doesn't work, I think that would be a very reasonable alternative. You want to make sure that somebody who really knows how to use Botox. There are a lot of, kind of people out there, plastic surgeons who give Botox. You really want to make sure it's given by a neurologist who knows about migraines and where to deliver the medicine. Is it safe for women with CADASIL to go IVF? Absolutely. There's that should be no different than the other women. Women with CADASIL will go under PGD, which includes pre-implantation genetic diagnosis, not really, to my knowledge, known to be a risk. And then there was a question, in the studies about pregnancy, was it stated if babies were IVF or had been tested for CADASIL in the womb, I assume in the womb, and would it make a difference? So with PGD, what is done is you create embryos in the test tube, and you check the embryos to see if any of them carry the Notch3 mutation. And then those that do not carry the Notch3 mutation are implanted back into the person who's going to become pregnant. The embryos that do have the Notch3 mutation are not put back into the person to become pregnant. A person who's usually a woman who wants to become pregnant, they can make the decision beforehand. If they don't know their own status of whether or not they're a Notch3 carrier, they and their partner can make a decision. We do not want to be told if there were any embryos that had the mutation, because if there were, that means that person was automatically a carrier, either the father or the person who gave the sperm or the person who gave the egg, whichever one of those was at risk. If you found an embryo with a mutation, that means that that parent is an obligate carrier. So what they do is in advance, they make a decision where they will not they do not release whether or not they found any embryos with mutation. All they tell the couple is, you were implanted only with embryos that did not have the mutation. So that's what they would do in those cases. And I hope I answered those questions. And that's it. Oh, actually, no, there are more. What is being done to educate the medical community about CADASIL? Yeah, it's a rare disease, and it's an uphill battle, but we're doing webinars. We're trying to get the word out. But I agree. There's a lack of knowledge about many rare diseases, CADASIL being one of them. So, often the patients and families know more about CADASIL. So be polite to your clinician who doesn't know about CADASIL, because to be honest, 99% of clinicians have never heard of CADASIL. Many neurologists have never seen a case. So be respectful, be part of the team that helps teach them about CADASIL so that you can educate them together. If they're not willing to learn about CADASIL, if they don't want to talk to another person, maybe a doctor who's an expert on CADASIL, if they don't want to watch webinars or read papers, maybe that's not the right doctor for you. There was a question about statins. There's no data supporting that statins are beneficial in CADASIL. In general, we only give statins if somebody needs a statin for another reason. So if they have elevated cholesterol, if they have another indication for a statin, then in general, we would give it. And I think that's what most of the guidelines suggest. And so somebody said that Dr. Ferrante, who's at NIH, said GOM is only in 75% of cases. And I'm not aware of that paper. I just actually met with her last week, so I wish I'd asked her about that. But I know in some laboratories you have to do electron microscopy to identify the GOM, and sometimes some labs don't do it well. There is data suggesting that if you do electron microscopy and immunohistochemistry, you increase your sensitivity for detecting the granular osmophilic material. So certainly, if you're testing for GOM, you do want to do both electron microscopy and immunohistochemistry, especially if one is negative, you want to go and do the other. And yeah, it's certainly present in the classic CADASIL cases, but on the less classical cases or the ones that are outside the epidermal growth factor domains 1 through 6, probably it's going to be, those are less typical forms, and those are probably more likely to not have GOM. And yeah, I think that's, and then for the variants that are non-cysteine altering, I think it probably maybe even a little less sensitive. But certainly if you find the GOM with a Notch 3 variant, it would support that variant is pathogenic. I've already gone about 12 minutes over, and I apologize. But looks like we already have, we still have 65 participants on, so almost no one left. I feel bad that I kept people on, but I hope that, thank you for there was a question, how many migraines would you consider too many? I only have 2 per year. I'm not sure if it qualifies for preventive plan. So usually if there are more than a few migraines per month, I think we would begin to think about putting somebody on a preventive medicine. 2 migraines per year, in my opinion, but I'm not the person having the migraines, I think would not usually be indicative of being on a preventive medicine. If you have, for most of my patients, if they have 1 a month, they can tolerate it. I usually don't like to add other medicines, but that would be a good discussion to have with your clinician. That's a great question. And then confirmed CADASIL in a brother and suspected CADASIL cousin diagnosed with MS following brain scans. So the number one misdiagnosis for people who actually have CADASIL is MS. Can MS occur in a family without CADASIL? Yes, it can occur. MS is not an uncommon disease. It's more common than CADASIL. So it's possible. But anytime we hear about a diagnosis of MS in a person from a family with CADASIL, it raises our eyebrows. It raises the hairs on the back of our head. And we always want to know, does that patient really have CADASIL? And we would recommend testing for CADASIL. It doesn't exclude the patient doesn't have MS, but there are some tests that can be very helpful and supportive of MS, such as certain kinds of electrical studies of the nerves in the brain, of the ears, of the eyes. Spinal fluid tests can help diagnose MS. So there are a series of tests you would want to do to rule in CADASIL and rule out MS. Great. Thank you for all the great questions. I'm going to let people go. Have a good evening. And again, I really want to thank my colleagues at the CADASIL Consortium and outside who've helped me put together this webinar and provided questions, including Doctors Jaidev, Majurzik, Salaway, Biller, and the coordinators on the CADASIL Consortium study. They've fed us patient questions as we go along as well, the staff of the CADASIL Consortium. Thanks and good night, everyone.